Chapter 15. Chapter 15 discusses the disorders of aging and cognition. The population of people age 65 and older in the United States has increased significantly since the beginning of the 20th century. So it is now estimated that around 36 million people in the United States are old. And I put that in quotes. Old age is usually defined in our society as the years past age 65. Older women outnumber older men by 3 to 2. As we see in childhood, old age brings special pressures, unique problems, and major biological changes. Additionally, we see psychological factors that are more likely to impact those of old age than those that are younger. Another statistic to share with you is that the percentage of elderly people in the population is expected to be more than 20% by 2030. And this is of no surprise with the advancements in medicine, with the focus on health. We are able to keep people alive longer. But we also need to figure out how can we instill a quality of life as we look at increasing the longevity of the population in general. So, not surprising, but we have significantly more elderly people now than we did even 10 years ago. And we're seeing that the percentage of the population is increasing greatly. Geropsychology is the field of psychology that is dedicated to the study, treatment of elderly people. So, looking at this from a mental health perspective, geropsychology is focusing on the unique stresses and circumstances that come with living to be 65 or older. The stresses of elderly people need not result in psychological disorders. However, studies indicate that as many as 50% of elderly people would benefit from mental health services. But fewer than 20% of the elderly actually receive them. So there's a large population of people out there that are not receiving the treatment that is necessary. Just like adolescence and young adulthood brings unique stressors and life events, the same thing occurs in old age. In general, we can say that the psychological problems of the elderly individuals can be divided into two groups. There are certain disorders that may be common in people of all ages, but are connected to the process of aging. So, what we see as people become elderly, we see an increase in things like depression, anxiety, and even substance related disorders. And this last one, with regards to substance related disorders, could be just the complexities of the medications that a patient is on and the way that they interact or the way that they contribute to the development of an anxiety disorder or a mood disorder. Another category for the elderly are disorders of cognition that result from brain abnormalities. With this, we see that individuals may develop delirium, mild neurocognitive disorders, and major neurocognitive disorders. We will spend time talking about these specifically in just a few minutes. But for right now, I want to go back and I want to talk about some of these disorders that are common across all ages, but how they also impact people when they become elderly. Depression is one of the most common mental health problems of older adults. It has the same features as depression in elderly and in the young people. So we don't see that there is a major shift of symptomology or sequela associated with depression. But we do see that as many as 20% of people experiencing this disorder will experience this disorder at some point during old age. And as was the case earlier in life, it seems to be higher in older women. If you remember back to our discussion regarding suicidality, perhaps you'll remember that elderly persons are also more likely to commit suicide than younger ones. And often, their suicides are related to depression. The prevalency of anxiety increases throughout old age. At any given time, around 6% of elderly men and 11% of elderly women in the United States are experiencing anxiety. Generalized anxiety disorder is particularly common and is experienced by up to 7% of all elderly people. Now remember, I really believe that these numbers are much higher, but we as a society, and specifically men, are less likely to report psychological problems. So at the very minimum, 7% of elderly people struggle with generalized anxiety disorder. Well, what are some of the causes that can lead to this increase in depression and anxiety? I think there are several things that we can consider. Number one, you've got declining health. You've got people that are struggling with their own health. They can no longer do the things that they used to do, that they used to enjoy doing. Perhaps that's taking away from their quality of life. They are seeing their loved ones, their relatives, their siblings, their spouse also have declining health. As we age, our kids grow older, and those that are blessed with longevity may see difficulties in their families with regards to their offspring or their grandchildren, and that is very concerning. We see that there are many things for them to feel anxious and concerned about. Think about the pandemic right now. The elderly are concerned that if they were to get COVID-19, they would have a very negative response to that. And maybe more concerning is what would happen with those in their lives that they love, their significant other, their brothers or sisters were to get COVID-19. There is loss. There's the loss of friends through death. There's the difficulties in getting together to socialize. So I think I've made my point here. There's a lot that happens later on in life that can lead to depression and anxiety. Disorders of cognition. With age, memory difficulties and lapse of attention increase. And they may start to occur regularly by age 60 or 70. Most cognitive problems have organic roots, particularly when they appear later in life. As you age, your body goes through physiological changes, the structure of the brain alters, and it leads to these cognitive problems. Some of the leading cognitive disorders among the elderly persons include delirium, neurocognitive disorder, and mild neurocognitive disorder. Now, when I was at the Jackson VA, I did a couple of rotations where I was dealing with people that were starting to have cognitive difficulties. And to be honest with you, it's not always an easy thing to assess. You see, there are things that occur cognitively that are fairly normal and associated to stress, anxiety, depression, or just getting older. Sometimes these are referred to as cognitive mishaps. Cognitive mishaps are when you get to the car and you realize you forgot the keys. You see someone that you've known for years and you can't remember their name. These are all quite common and are quite a normal feature of stress or aging. This happens to me. I can't tell you the number of times where I've walked into a room and I think to myself, all right, why did I come into this room? What was I going to do? Or while I'm lecturing and the word I'm wanting to use escapes me. Perhaps you've even noticed that across some of the lectures. I try to cover it up by extending what I'm going to say or repeating what I say until that word comes to mind. I don't remember what the word was yesterday while I was recording a lecture, but there was a word that I could not come up with that I kind of stammered a little bit until it came to mind. Even at your age, you've probably had some of these experiences where you've forgotten some things. That usually is because of stress or because of distraction or other things that are going on in your life. As people move through middle age, these memory difficulties and lapse of attentions increase. Like I said, as you approach that age of 60 or 70, they're likely to occur more frequently. Sometimes, however, people will experience memory and other cognitive changes that are far more extensive and problematic. While problems in memory and related cognitive processes can occur without biological causes, an example of this would be dissociative disorders. More often than not, cognitive problems have organic roots. And so let's turn now and look at some of the specific types of disorders of cognition that are likely to occur in old age. The first one that I want to share with you is delirium. Delirium is characterized by a major disturbance in attention and orientation to the environment. More specifically, what happens is the awareness of the environment becomes less clear and often accompanies great difficulty concentrating and thinking in an organized way. This difficulty with thinking, difficulty concentrating, this breakdown of the awareness of the environment leads to misinterpretations of things that are happening in the environment, possible illusions, and on occasion, hallucinations. So these are individuals that become, for lack of a better term, disoriented. They might forget where they are. They might forget who they are. They might forget what year it is outside. They might have some difficulties with memory. But here is the key factor to remember when dealing with delirium. With delirium, its onset is typically very quickly. Over the course of hours or in a few days at the most, the individual experiences fast moving and fluctuating disturbances in attention and orientation to the environment. So delirium has a rather quick onset as compared to some of the neurocognitive disorders we're going to talk about in a few minutes. Now, this individual also very quickly displays a significant cognitive disturbances. Most of us have been around people that have neurocognitive disorders such as dementias or Alzheimer's. And we know that's a gradual process that can fluctuate from day to day. It may take years for the cognitive impairments to finally solidify. But again, what we see in delirium is that it can happen very quickly. One of the primary causes of delirium is medication changes, usually in a hospital setting. So if you're helping to watch grandma or grandpa and they're in a hospital and they've added a new medication or they've changed up the medication and you're noticing some significant orientation changes in your grandparents, let the nurse or doctor know, because it could be that there is some interaction that is occurring between the various medications that is causing the delirium. And the nice thing about deliriums that are caused by medications is that very often when you discontinue the medication or you change the medication, the symptoms go away and they return to their pre-functioning level before they started the medication. This affects fewer than 0.5% of the non-elderly population. It affects 1% of people over 55 and 14% of those that are 85 years of age or older. As I said, it typically develops over a short period of time, usually hours or days, and most commonly in elderly individuals. Now, it can occur in any age group, including children, but it is most common in the elderly. I've already shared with you the most common cause, and that is changes in medication. But there are other things I want you to be aware of. Fever. Delirium can accompany certain diseases and infections. Poor nutrition. Head injuries. Strokes. Stress. Sometimes what you see is following a surgery then and the trauma of surgery and the medications that are associated to decrease pain and to treat the multiple side effects that go along with surgery can also cause delirium. Sometimes intoxication by certain substances can lead to disorientation. Neurocognitive disorders. Most of the time, when people think of or hear about neurocognitive disorders, they automatically think about Alzheimer's. And much of the neurocognitive disorders that we see in our society are related to Alzheimer's. But there are more neurocognitive disorders than just Alzheimer's. There are different types of dementias that have different types of biological factors. So, in general, neurocognitive disorder is characterized by significant decline in at least one area of cognitive functioning. So it is possible for individuals that have neurocognitive disorders to have different areas of cognitive functioning that are impacted. I want to go through and I want to share with you some of these cognitive functioning areas. First of all is memory and learning. This is where individuals have difficulty either recalling past information, learning new information, or a combination. So sometimes what we see is that people have great recall for events that occurred 20, 30, 50 years ago, but they can't do a simple learning task right now. In neurocognitive assessment, this is easily done by the following. You would say to the patient, I've got 3 words that I want you to remember. I want you to remember these 3 words, and I'm going to ask you for them in a few minutes. The 3 words I want you to remember are car, hat, tree. Now, what were those words I wanted you to remember? Car, hat, tree. Okay, remember those words? I'm going to ask you for them in a little bit. Time passes, you come back to me, you say, what were those 3 words that I wanted you to remember? A lot of times, people that are struggling with neurocognitive disorder cannot remember car, hat, and tree. So they can't learn new information. Attention. They may have trouble attending to what's going on in their world right now. They may just kind of wander off in their mind and not be aware of what's going on. The attention and the memory difficulties may be linked. One of the things that I noticed when I was dealing with people that had dementias was what they watch on TV changes. Elderly people may not have the capacity to attend and to remember the storyline for a movie or an hour TV show. But they might be able to watch Fox News, CNN, the Weather Channel. Well, why would they watch that? Well, the stories are brief, and then they switch and they go to a different story. I think we also see this with regards to sports, that they can watch women's basketball, or they can watch hockey, football, any sport, and keep up with what's going on, because there's a constant reminder right there on the screen. It tells you what the score is. Sometimes they have trouble with visual perception. You might ask them to copy a shape that they're looking at on a piece of paper, and they're unable to do that even though they have that shape right in front of them. There can be difficulties in planning and decision making. They may not have the capacity to plan what they're going to do during the day, or what they're going to organize. One of the things that I noticed with the men I worked with in the VA is they may have rebuilt motors all their lives, but then they could get to a point where they no longer could put them back together. Well, they could still take them apart. I mean, taking things apart's the easy part. It doesn't take a lot of planning and critical analysis and decision making. But putting back together is a different thing. So that actually was one of the things that I would ask relatives, and they would say, "How did you know that Tom could no longer put the lawnmower back together?" It's pretty common. Language ability. In very significant long-term neurocognitive disorders, they lose the capacity to understand and to produce language. Social awareness. I describe this as they lose their filter. They lose the ability to process in the frontal cortex what is appropriate in a social situation. And so this can also lead to significant personality and behavior changes. Another thing that I would assess for in dealing with people that are in the process of neurocognitive decline is things like, does grandma use language now that she never would have used 10, 20 years ago? Yeah, I mean, she swears all the time now, and she never would have swore 10 years ago. Well, that's part of this filter that's breaking down and some of these personality and behavior changes. It's not uncommon for people to become very angry while they're going through this decline. Another behavior and personality change. Now, these cognitive function declines interfere substantially with the person's ability to live independently. They may no longer be able to take care of themselves. It may come to a point where it is a health issue, a safety issue. They leave the stove on, they leave the car running, they forget to take their medications. It also can impact others around them. Perhaps you know someone, or perhaps you have been involved in the care of a person who is experiencing Alzheimer's or another dementia. It is very difficult, very draining. Okay, so it is also possible to have mild neurocognitive disorder. I probably should create a separate slide for this. So make sure you write this information down. But a mild neurocognitive disorder is a disorder in which the decline in cognitive functioning is modest and does not interfere with the person's ability to be independent. So it is possible that the individual has cognitive decline, but it's not to the point that there needs to be major intervention. It could be that the person could benefit by creating lists, by going through routines, by staying in a routine, by having somebody stop by and check on them every day or two, putting the pills in a dispenser so you've got morning and evening dosages. Heck, I already do that. It's not because of memory or cognitive decline. It's just that I get so busy, I don't remember whether I've taken it or not, or I forget to take it because of what's going on in my life. So it is possible for there to be a mild neurocognitive disorder. We'll see kind of the difference here on this screen. I'm not going to go through all of this. I've pretty much explained all of this in the prior slide, so feel free to pause this and make any notes if there's something that you want to add to your current notes. The occurrence of substantial cognitive decline is closely related to age. It's no surprise to you that the older we get, the more difficulty that we have with cognitive disorders. Fewer than 1% of all 60-year-olds have major neurocognitive disorders, compared with as many as 50% of those who are 85 or older. My wife is blessed to still have both of her parents. Her dad is 94 and her mother is 84. My 94-year-old father-in-law is as sharp as he ever was. He continues to read daily, to do puzzles, keeps up on current affairs, is a very sharp individual, and will always, I really think will always retain that sharpness. It could decline at this point, but he is very sharp. My mother-in-law is pretty typical for her age. She has some cognitive decline, has some difficulties with memory and confusion. I'm not even sure I would classify her as having any type of even mild neurocognitive disorders, but rather it's just kind of part of that aging process. And so it is possible to live to be significantly older and to still retain the majority of your cognitive functions. I want to say just a few things about Alzheimer's because it is such a prevalent disorder. So, Alzheimer's disease is the most common type of neurocognitive disorder and can account for as many as 2/3 of all cases. Around 5 million people in the United States currently have this disease. The prevalence increases significantly among people in their late 70s and early 80s. This disease sometimes can appear in the middle age, but most often occurs after the age of 65. So it's rare for someone under 65 to develop Alzheimer's. Growing up, I had a very intelligent man in my life that developed early onset Alzheimer's. He started to show symptoms at 55. That was a very difficult thing for he and his family to observe. Here you'll kind of see the DSM checklist. We've already talked about the major or mild neurocognitive disorder. We see memory impairment as being the prominent feature. Alzheimer's is genetic, but we don't always see the genetic link in the family. Okay, so it underscores the disease. Genetic indications or family history underscores the diagnosis, but it's not essential to the diagnosis. So it is possible for someone to be the first one in their family to be diagnosed with Alzheimer's. One of the things you have to do with all of the neurocognitive disorders is you need to rule out other medical problems, that it's not being caused by some underlying health issue or it's not being caused by medications. Technically, sufferers receive a DSM-5 diagnosis of mild neurocognitive disorder due to Alzheimer's disease during the early stages and major neurocognitive disorder due to Alzheimer's disease during the latter stages. Now, in just a few minutes, we'll talk about how we can't be certain about Alzheimer's as being the cause until after an autopsy has been done. But given the statistics, given some of the neuropsych testing we can do, and the ruling out of other causes, we have a pretty good indication that there is Alzheimer's going on. Okay, so on the screen in front of you now is kind of the disease progression. The time between onset and death can differ significantly. Typically, it is 8 to 10 years, although some people may survive for as many as 20 years. It usually begins with mild memory problems, lapse of attention, and difficulty in language and communication. It might start as simple as just word finding problems, the inability to find that word. For example, one of the things I would do in assessing individuals with neurocognitive impairment, and I would show them a comb, and I would ask them, could you tell me what this is? Most of the time people would say, yeah, it's a comb. Sometimes they'd call it a brush, which was incorrect. And sometimes they couldn't even come up with the word comb or brush. They'd say, well, that's what you run through your hair in the morning to straighten it out. Yeah, that's how we use it, but what is it called? We then see that as the symptoms worsen, the person has trouble completing complicated tasks and remembering important appointments. Now, there's fluctuations in all of this. There are good days and bad days. There are days where grandma seems just fine, and there are other days that you are very concerned. And I've actually seen this lead to significant family disharmony because people that live close to the relatives see the changes, but those that come visit might hit grandma on a good day and they don't see any of the changes, and there's disagreement in the family as to what is going on. Then we see that they start to have difficulty with simple tasks. Distant memories are forgotten, and there are changes in personality, and it often becomes very noticeable. As the neurocognitive symptoms intensify, people show less and less awareness of their limitations. They're not aware of how they're being impacted, and they deny that there are problems. Now, this denial can start early on, and these individuals are very efficient at creating ways to try to mask or cover up the decline. They can use humor. One of the common things I would see is that they would start using pet names. So they may not be able to remember the different names of their grandchildren, so they call everybody honey. Hey, honey, come here. It's so good to see you, honey. And so they develop ways to mask or to cover up the decline. Eventually, they become fully dependent on other people. They lose almost all knowledge of the past, and they fail to recognize the faces of even close relatives. Interestingly, these patients usually remain in fairly good health until the later stages of the disease. I don't know if this is because of the lack of awareness of what's going on in their environment. It decreases the stress in their lives, so they're not having that stress that's impacting their physical health, or what it is, but I've seen that several times across patients and family members. Okay, as I said earlier, the diagnosis of Alzheimer's disease can only be made with certainty after death. So, through a biopsy of the brain during the autopsy, they are able to identify senile plaques. Now, here on the screen are the yellow or the senile plaques that are highlighted in yellow and black spheres. Okay? So this, as you look at this large sphere in the bottom right-hand corner, that is a senile plaque, where the other yellow and black are neural fiber tangles. Senile plaques are sphere-shaped deposits of a small molecule known as beta amyloid protein that form in the spaces between cells in the hippocampus, the cerebral cortex, and other areas of the brain and blood vessels. The neural tangles are twisted protein fibers that are found within the cells of the hippocampus. Scientists do not fully understand what role these excessive numbers of plaques and tangles play in Alzheimer's disease, but they suspect that it's very important. So current research, current theories focus on these plaques and tangles as they may contribute to the formation of Alzheimer's disease. I've already said that most cases of Alzheimer's can't be diagnosed until an autopsy is performed. However, what we're seeing is that brain scans, which reveal structural abnormalities in the brain, are now commonly viewed as assessment tools. Several research teams are currently trying to create tools that can identify persons likely to develop Alzheimer's disease and other neurocognitive disorders. And the PET scan is a major player in this. Overall, the PET scans, when they're administered years before the onset of symptoms, are able to predict mild neurocognitive impairment with an accuracy rate of 71% and 83% for major neurocognitive impairment. I expect we will someday be able to have some type of test that will predict the onset of neurocognitive functioning. I hope that we also can create something that will effectively and easily prevent the development of neurocognitive decline. That's the end of the first lecture. Please go to the second lecture when you are ready.